Hello everyone, my name is Asya Ali and today we'll talk about disorders of maxillary sinus. Odontogenic sinusitis is the inflammation of mucosa of any of paranasal sinus. Maxillary sinusitis is usually odontogenic in origin because of its close proximity with the maxillary teeth. The condition, if not treated, may spread to involve other sinuses. It is the three types: acute, condition present less than 2 weeks; subacute, from 2 weeks to 3 months; and chronic, more than 3 months. Acute can be suppurative or non-suppurative inflammation of the antral mucosa. Signs: tenderness over the cheek, anesthesia of the cheek, and severe infection may lead to mild swelling, and teeth may show tenderness on percussion. Symptoms: patient may give history of cold 3 to 4 days prior to the acute attack, postnasal discharge, and constant throbbing pain. Is more severe in the morning and evening. Maxillary teeth on the affected side may be painful. Unilateral fall, nasal discharge, profuse with the lowering down of the head. There can be occlusion of ostium of the maxillary sinus, and generalized symptoms like chills, fever, sweating, nausea, difficulty in the breathing, anorexia, may due to swallowed bass. Radiography: Waters view or experimental, the most valuable radiograph. Acute sinusitis: the affected antrum shows uniform opacity, sometimes fluid level is discernible. In chronic sinusitis, the radiographs show pansinusitis, fluid level, thickened lining is also seen. Axial CT scan show right maxillary sinusitis and pre-septal cellulitis in this image. Management: classical antral regimen includes bed rest, plenty of fluids, maintenance of oral hygiene, and antimicrobials, macrolides like erythromycin, broad-spectrum group like amoxicillin. Nasal drops or sprays like ephedrine sulfate or xylometazoline hydrochloride. And technique for nasal sprays are Moffitt position and Meigen technique. Non-steroidal anti-inflammatory analgesic like aspirin, paracetamol, ibuprofen. Chronic maxillary sinusitis may be due to persistent dental focus, chronic rhinitis, chronic infection in the frontal or ethmoidal sinus, allergic conditions. Condition sometimes is asymptomatic. Pain and tenderness in the area of antrum is found usually in the acute exacerbation. Unilateral fall discharge through the posterior nares. Fetid odor with the bad taste in the mouth. Diagnosis: based on history of repeated attack of acute mucopolonitis rhinitis, long-standing nasal or postnasal discharge. Anterior rhinoscopy shows nasal congestion and mucopolonic material in the middle meatus. Inspection of oropharynx reveals descending pharyngeal exudate. Presence of an obvious or antral fistula may be there. Prolapse of polypoidal mass into the mouth forming a lump may be seen. In this image, clinical photographs show swelling extraorally on the right cheek region and intraorally obliterating the vestibule. The radiograph or panoramic view show smooth outline, dome-shaped soft tissue density on right maxillary sinus. Coronal bone window CT image shows lesion engorging on the large volume of the maxillary sinus cavity, and sagittal bone window image shows expansive process associated with the apex of maxillary first molar. And in this image, we show the chronic maxillary sinusitis. Management: the management requires eradication of the related dental complication. If the chronic sinusitis is caused by chronic periapical infection, the unaffected tooth must be extracted and socket closed surgically completely, as there is risk of parenteral fistula formation. If there is already communication with the maxillary sinus and blood flow fails to organize and the socket gets infected, then there will be persistent chronic maxillary sinusitis. Surgical management: indication is bilateral chronic sinusitis with polyp, fungal sinusitis, presence of complications, tumors, and CSF. Contraindication is presence of extensive polyps and headache of midfacial pain, medically compromised, or hyperplastic sinusitis. Maxillary cadwal leaf separation. A surgical procedure for assessing the maxillary cadwal leaf separation sinus can be done for diagnostic biopsies, antral growth, or for therapeutic purpose. Indication is chronic sinusitis with severe degeneration of the lining, polypoidal growth, mucocele in the lining, foreign bodies in the sinus, for diagnostic purpose, or for elevating the fracture of zygoma in the floor of the orbit. In this image, intraoral incision for cadwal separation, creation of bony window withdrawal, perforation area for window, and enlarging the bony window at the anterior maxillary wall with rongeur or burr. This operation may have complications such as bleeding, facial asymmetry, cheek discomfort, or damage to teeth, and patients may have discomfort 1 week after procedure. Another surgery is functional endoscopic sinus surgery. Purpose is to restore normal paranasal air sinus mucociliary function. Like in this image, the surgeon inserts endoscope, small tube, and camera into the nasal cavity through nostril, detects any abnormal tissue or polyps that makes sinus impossible for drainage. Indication in recurrent sinusitis, in chronic hyperplastic sinusitis, in chronic sinusitis with mucocele, in fungal sinusitis with immunocompromised patients, and neoplasms and orbital cellulitis. Fungal disease. Most fungal diseases of the maxillary sinus involve the organism Aspergillus, which live within the modulus and spores and regularly inhaled into the respiratory system. When infection occurs with Aspergillus in relation to dental foreign materials, the infection is normally contained within the confines of the maxillary sinus. Foci of infection may lead to dystrophic calcification and formation of rhinoliths, which may be seen on dental radiograph. Large are known as fungal balls. Like in this image, left typical sinus CT scan of patient with mycotoma fungal sinusitis of right maxillary sinus. Right, a view from endoscopic during sinus surgery to remove fungal material and restore sinus drainage. Treatment is normally surgical with removal of any predisposing cause, and this is also increasingly by being provided endoscopically with the aim of restoring normal mucociliary function. The oral intrafistula is the pathological communication between the oral cavity and the maxillary sinus, which is lined by epithelium. It's a chronic version of the acute communication of the maxillary sinus into the oral cavity. It facilitates the regurgitation of the fluid from the oral cavity into the maxillary sinus and contamination of the sinus with the oral microbial flora, which leads to chronic sinusitis. Etiology: extraction of teeth, destruction of the portion of the floor of sinus by periapical lesions, perforation of the floor of the sinus and sinus membrane with the injections use of instruments, forcing teeth or roots into the sinus during attempted removal, extensive trauma to face, surgery of maxillary sinus, chronic infection of the maxillary sinus like osteomyelitis, teratoma, destruction of the maxilla such as gamma-involved palate, infected maxillary implant dentures, and malignant disease such as malignant granuloma. Clinical features: regurgitation of fluid in the sinus when the patient tries to drink the water, loss of resonance and nasal twang to the voice. When the patient's nostrils are compressed and he is asked to blow through the nose, it produces deflection of the cotton wool filaments, frothing or bubbling in the blood present in the socket of the extracted teeth. Unilateral epistaxis following the trauma. In a chronic case, unilateral foul-smelling pus discharge may be present and signs of maxillary sinusitis are present due to secondary infection from the oral flora and inability to whistle. In this image, popping of enteral polyp through long-standing oral enteral fistula. Diagnosis is based on history. X-ray show haziness of the sinus when the sinusitis set or when there is bleeding in the sinus. This large foreign body, if it's large, may show in the X-ray. The intraoral periapic radiographs show the defect in the bone above the apex of the root, with the loss of corticational floor of the sinus. If the fistula is large, clear-cut communication between the socket and sinus is seen. Like in this image, regurgitation of water through nostril. Patient gave history of extraction of upper left first molar 2 months back. Surgical exposure for enteral communication. Management: 3 to 5 mm healed spontaneously. Ideal treatment is immediate surgery followed by antibiotic prophylaxis, and the acute closed by simple reduction of buccal and palatal socket wall, followed by acrylic splint. Antibiotic at nasal decongestant, analgesics, and enteral lavage. Surgical closure: factor determine flap selections like size of communication and timeline of diagnosing and the presence of infection. Management: if small, advancement of buccal and palatal gingiva and closure. If it's large, we have many flaps like buccal flaps, palatal flaps, regional flaps, distant flaps, and bone grafts. This is Berger's flap, Rehrmann's technique, Moczar's flap, straight advancement flap, Kroger's modification, closure of fistula by palatal rotational advancement flap, palatal hinged flap, combined local flap, posterior and anteriorly based tongue flaps, use of buccal fat pad, and bone graft. And thank you for your listening.